Just our disclosures here.
A few disclosures, but nothing too drastic, mainly around Albavance and guidelines and some sponsored for speaking at some events and some C. diff fecal microbiota trial that's now closed. Yeah, so I thought our objectives today, or we thought we'd chat about, the benefits that we've seen by using the NAPs for a few years now, both at a few sites, but also across the province, and hopefully highlight some of the successes we've had with it, and then highlight some of the challenges we've had, especially recently about implementing it around privacy and that type of thing, and some of the pearls of doing this survey. But I'll hand it over to Andrea. She's going to do some of the first bits, and then I'm going to pick it up at the end.
So NAPS is the out of Australia. They've developed this, and it's the National Antimicrobial Prescribing Survey. And Canada picked this up, I believe, around 2017, and looking to basically wanted to facilitate a way to measure antimicrobial use across the country to provide some benchmarking, but also to assist us in a way to not just measure the quantity, but to measure appropriateness of prescribing and then identify targets for the antimicrobial stewardship interventions. And so we're going to talk a little bit about how we've used NAPS to do this. This is the form that comes as part of the NAPS database, and you can print these off or you can input directly into the database. So this is some of the information that's collected. And then there's lots of training available on the site as well, how to do it, your data collection forms, detailed reports, and the things that you can get out of the system. There is standardized appropriateness definitions, which has helped to sort of allow us year over year to compare our appropriateness, because there's an endorsed standard way of assessing the appropriateness of the prescriptions. And once you've got everything into the system, you can get this nice little dashboard easily printed out, which sort of gives you the percentage of patients that are on a specific, on one antimicrobial at least in your different hospitals, compliance with guidelines, as well as appropriateness of the antimicrobial prescription, and then some dashboard stoplight type ones with indication, surgical prophylaxis, documented stop date, etc. They also didn't fit on here, but will also give you the top antimicrobials by indication, they will give you the most used antimicrobials as well as the most prevalent indications that antimicrobials are being used for. But let's start back at the beginning of our journey. And in 2018, we did do a survey just at a couple of sites to kind of test it out. And then in 2019, we did our full first survey across all of our main sites. So 2 tertiary care hospitals and 9 community hospitals across the province. And this was our results. Basically, we only had about 18% that were compliant with guidelines, but the bigger point here was that over 55%, we didn't have guidelines available. And when we were looking at our guidelines, we were looking specifically for guidelines like our local guidelines, provincial guidelines, not IDSA guidelines or anything like that. And then looking at appropriateness, we had just a little over 55% considered to be appropriate. And so we realized we had a fair amount of work to do. At the time, all of our guidelines were housed on a web page, a website that was part of our hospital internet site was available outside of the hospital as well, but it didn't look quite this pretty. It was pretty basic in its early days, but everything was just housed here. And we were working on a way to get it more at a point of care. And so we were in conversation with First Line to get this into place to make our guidelines more accessible for our prescribers. And we were struggling to get funding for this. But in March of 2020, thanks to COVID, um, when we could say that we could put COVID guidelines in the palm of the hands of the prescribers easily with First Line, this was quickly adopted and put into place. And so we've added we started off with just a few COVID guidelines and a few guidelines that we had in place on our website, and have added to it as we've gone along. And then the other thing we did with the NAPS data, because we knew we needed to increase our what we had for guidelines, but how do we decide what we need to do? We use the data from the NAPS to determine what were the most common indications we were seeing within our facilities, both including topicals and not including topicals, and sort of using this as a way to triage what guidelines we were going to work on next and start to develop. And so from that, you can see that we've had some big improvements over the years that we have been doing NAPS since 2019, going from 55%, over 55% of our prescriptions not having a guideline available to now just a little more than 21% not having a guideline. And then in the same frame, 18% being compliant with guidelines, up to over 46% now complying with our local guidelines. So some good improvements there. And then the last one that I'm going to share about before I hand it over to Paul to talk about some stuff is topicals weren't one of the things that we were really big on our list of things to be looking at. But in conversations with Sinai Health, who are holding they are the ones that have the Canadian, that's where it's being housed. They really wanted us to include topicals so that benchmarking across the country could be the same. So others were doing it. So we did. And interestingly, we found that down in one particular area of our province, there is a huge amount of use of this Dr. Loverich's cream. So Dr. Loverich was a physician there. He wasn't there anymore, but his cream lived on. And it was a combination of nystatin and hydrocortisone in a liquid antacid. And so because it had that nystatin cream in it, it was getting classified as antifungal use, an antimicrobial, to be part of the NAPS survey. And so most of the time, the use of the nystatin in this was completely inappropriate, and using some communication, some education, the Choosing Wisely's recommendations to not routinely use a combination of corticosteroid and antifungals as our backing, we were actually quite successful with this small little project to greatly reduce and almost eliminate the use of this Dr. Loverich's cream in this area of the province. Okay, handing it over to Paul.
That's great, thanks. And yeah, and to that point, a lot of the help and leadership on this has come out of Toronto there. So a lot of thanks to Miranda So and their crew really helped us get this going. And certainly across the province, particularly in the early days, and still now, we rely a lot on other clinical pharmacists, students, residents, the like, to do some of this work. So we've been pretty lucky at being able to get this done at least every so often across the province. So, just highlighting a few other things, and the nice thing about NAPS compared to other point prevalence surveys you may have done or we've done, is that you can get the results pretty much in, well, not real time, but very quickly after finishing your survey. So once you finalize all your data input, really you can start generating your reports, as opposed to waiting for, being sent out and then getting results sometime in the future. So it's very helpful that way. And obviously, we collect a lot of DDD data, DOT to some degree as well. But we are still a paper-based, non-electronic order entering system. So that does limit a little bit of what we can do. And even so, it is hard to get at appropriateness, of course, as we all know. So as Andrea mentioned, doing these surveys is helpful, at least as a snapshot to get a sense of appropriateness, what people are using antimicrobials for in your institution or centers across your province. And then you can start, getting a sense of, the percentages of appropriateness, looking at year-to-year changes. I find it helpful when talking to leadership or other stakeholders, really to highlight where you're using the most antibiotics and really can kind of focus a lot of your interventions around those things. And no surprise, for the most part, it's pneumonia, cystitis, cellulitis, both for overall use and most inappropriate use, of course. So, getting some of that data can certainly be valuable when you're chatting with medicine, for example, or ICU, and really kind of helps you focus some of your attention. Next slide, please.
I'm trying and it's not. Oh, there we go.
Yeah. And again, I suspect you can, but we certainly can do, DDDs and that type of thing. So it is another way of looking at your total antimicrobial use. This is just a snapshot of, I think, all the years combined, actually, and the top, whatever it is, 7 antimicrobials or so, systemic antimicrobials. And it can be quite powerful. Obviously, you see ceftriaxone being your most common antibiotic here, which is, I guess, good and bad, but it has served, and that has kind of emerged along with our DDD data as really an area to focus on, because of course we've had fairly high C. difficile rates recently, and we know ceftriaxone is a strong driver of C. diff. So, presenting data like this, saying to folks, prescribers, that look, we use a lot of ceftriaxone, more than any other antibiotic across the province. Can we do something here? And this has really led to a few little projects, nothing we can report on yet, but the big one is trying to decrease the duration of ceftriaxone for folks coming in with CAP. I'm sure it's similar there, but often our patients get thrown on at often 7 days or whatever of ceftriaxone, really without much thought. And trying to get folks to do that 48 to 72 hour timeout, particularly on the hospitalist units. And really, if they're doing well, non-bacteremic, then obviously they can usually get down to orals to complete a total of 5 days. So we've been doing a little bit more, education, some minor interventions around that, but really just highlighting that some of these types of data can help drive your interventions. Another thing that emerged along those lines was azithromycin use. And of course, it's always a bit dangerous comparing, in our case here, zone to zone, because it is to some degree different patient populations. Although, outside of Central Zone, which has Halifax and Dartmouth, that's more tertiary referral center, probably would argue the other zones are more comparable to each other. But certainly you'll see different patterns of use across your province, I'm sure, and we certainly do here. So we've seen high rates of azithromycin use, and particularly in Northern Zone, which has kind of 3 large regional hospitals, and also in Central Zone. But this has persistently been a little bit of an outlier when we looked at our DDD data as well. So kind of early in the pandemic and kind of during the pandemic, we were trying to think about how we could address this. Through the NAPS, we knew most folks were obviously on azithromycin, and to some degree, clarithromycin, obviously for pneumonia, CAP coming into hospital as part of a regimen with a beta-lactam. And, we saw durations that were longer than we would like to see. Obviously, most folks did not have Legionella, so 3 days of the 500 was more than sufficient. And we thought that was a pretty easy intervention at a pharmacist level as an interchange. Challenging, as you know, to get prescribers to not use a macrolide. It is in the IDSA guidelines. I don't think everyone with a CAP that comes into hospital needs a beta-lactam plus a macrolide, but such is life. Anyway, people are going to use the macrolide, that's fine, but we want to, if you're going to use it, optimally as possible and, as short as duration as possible. And also some of this came out about clarithromycin interactions and the concerns and a few cases we had of issues there. So really we said, well, macrolides, particularly Zithro, is not used for much else, particularly on the inpatient service. So can we basically just have an interchange to, if you get prescribed a macrolide, let's just get them over to a Zithro 500 for 3 days. We weren't too dogmatic about IV versus PO at this point anyway. So he's just said, let's do that for 3 days and see if that helps. There were exclusion criteria, not many, of course. MAC prophylaxis and HIV, not common to have MAC treatment in-house, severe pneumonia in ICU, concern of Legionella. Some of those, all those things obviously are quite rare. So we thought it was quite safe, keeping those balancing measures in mind. So yeah, we rolled this out. There wasn't really much fuss. We had, liaised with medicine and respirology, and everyone seemed pretty cool with it. So that was good. So, and our uptake has been pretty good. We've had other pharmacy interchanges, which a little bit harder, either to get buy-in or enforce or to do, especially during these busy times. But this has had pretty good buy-in. And, some preliminary data that Andrea put together was, you can see on the left, the pre-intervention. You'll remember the central and northern had high overall macrolide use, but in central, decent durations, whereas longer durations in the other zones. And then, so kind of along with that, the percentages over 3 days. So more than 50% outside of central zone were over 3 days. And again, that should be pretty rare. So that's pre-intervention, and then post-intervention. No, we don't have any stats on this at this point, but the trend certainly is some improvements, particularly for those zones outside of Halifax, northern zone and western zone, trying to at least decrease the duration for those zones to using the macrolide. So, trying to at least minimize macrolide use, or if we're using it, use it in the most optimal way as possible. And then one other thing that I find helpful, and that sometimes we don't think a lot about, particularly in ID world, in stewardship probably a little bit more, but is around surgical prophylaxis. And I'm sure most of you folks are aware of, surgical guidelines, WHO, CDC guidelines, and they do talk a fair bit, particularly the WHO, on duration of surgical prophylaxis. Really, for the vast majority, no one really should be getting surgical antimicrobial prophylaxis post-op, but, you do what you can, and often folks will tolerate up to 24 hours. Certainly giving more than 24 hours post-op definitely is of no benefit. So in the early days before COVID, and again, that's one problem. This is just a snapshot, but on this given time we did the survey, we had a fair amount of folks receiving surgical prophylaxis post-op. This would include all surgeries, of course, across the province. And was useful to compare that to the Canadian benchmark, which was still pretty high, but better than what we were up to. So we did a variety of things. There was surgical bundles that were coming out. So we had those updated. We updated our guidelines, had that in first line more readily available, engaged anesthesia. So we have, our charts in the OR suites in many parts of the province. And really, again, we're paper-based, so all the pre-printed orders, really being aggressive at, well, one, getting rid of clindamycin, but also to really either get rid of or max out post-op prophylaxis at 24 hours. Obviously, ortho being the big one. Gen surge was less of an issue, but ortho, neurosurge, all those surgeon types. And really, we've had decent change over time. Again, there's going to be some wiggle room here. But you could grind down a bit more and do this more frequently and just do targeted surgical prophylaxis. And there is lots of options for that in apps. So, we have had some decent trends in improvements in that. There's just one example that in 2023 it was a lot better. So I do think things are getting better in that regard. But again, it is nice that this does highlight surgical prophylaxis. It's not all point prevalence surveys do that. And you can do some Canadian benchmarking, which is always pretty powerful when you're trying to instill change. Yeah, so we don't have too many slides left, so I have lots of time for discussion and questions if desired. So we've seen pretty good correlation. We've had a good improvement with appropriateness doing these point prevalence surveys over time. So the gradual trend is improvement in appropriateness, really fairly grim when we first started, up to about that, more realistic 73% appropriateness with time. And, we've tried to do this as standardized as possible. Obviously, there's going to be wiggle room from year to year. It's been usually the main stewardship crew, myself, Andrea, and then a few of our key pharmacists that have kind of lead it in each zone and then have help from others. So we try and adjudicate it as reasonably and consistently year to year as possible. To try and get rid of some of that variation. So often we will adjudicate appropriateness by that chart that was mentioned earlier. If there's any uncertainty, then we'll often have a group discussion and we'll usually have a few meetings and go through those. And initially that took a lot of time. Now we're relatively quick at it. We try and do it around the same time every year, which is usually in November or so, to try and not change the patient population too much with respiratory season and the like. But anyway, overall, we've had decent trends in improvement in appropriateness. And the nice thing about First Line is you can capture your users. And we have about 2,000 unique users at any given time. Overall, good improvements over time in users across all disciplines, really.
Sorry, it doesn't want to advance. Oh, there we go. Okay. So this is actually the last slide, but there's a fair bit to talk about here. So as mentioned, some of the barriers or some of the things that can cause some constraints in actually doing these point prevalence surveys. One that we've come across just in the last year or so was privacy. When we first started doing this, it was a quality initiative, didn't really require us to have privacy involved. But in trying to make this a national program where we can do the benchmarking and our data will be going to Mount Sinai in a non-patient identifiable form, we did have to go through privacy to get that all looked after, and there were a lot of hoops to go through. It took us just under a year to actually get through everything, but now we're all set. And we can be part of the benchmarking, and as that goes through, it's a lot of it should get easier for other sites as well, because the data is all there as to how it's done. So if you guys want to do that, I can share all of the data that we got from them as well. it will allow sorry, I just got barking dogs here that have just distracted me. It will allow us to do the benchmarking across the Canada and have that all, which I think is important to be able to see how we compare and allow us to see what's going on. So that now is done, and we don't have to worry about it. But it was a bit of a juggling act and taking some time where we had to miss doing it for a year to make sure that we had everything in place. So planning ahead would be good to get this in place before you start the process if you are looking to do that. Then the bigger barrier and a bigger time is the time constraint that comes, and it seems like a daunting thing to set aside a large amount of time to do these point prevalence surveys, but I hope that what we've shown you here today will show the value in dedicating a little bit of time to this and sort of carving it out. So as Paul mentioned, we pick a 3-week period in November. We try to be consistent in the time of year, so we are comparing apples to apples and oranges to oranges with the seasonal bit for antimicrobial use. And it 3 weeks, it allows people to sort of fit it into their schedule. We have actually extended it even longer if needed, as long as it's sort of still in the same sort of seasonal time frame. And we have tried some different things that weren't effective, and we've tried some things that were much more effective. So I'm going to tell you a bit of both so that you can learn what not to do, and then maybe some of the things that do work. So initially when we set this up, we were doing the paper-based format. So those pages that you can print off from the NAPS database, and we would dedicate usually a day or two at the community sites, and then we'd need a little more time at the the larger tertiary care sites. And so in that 3 weeks, we could get all the sites be assessed, and so we'd have the pages all filled out. The problem is then we had to input it into the database itself, and we would sometimes, we would block off these dates that we would do the actual survey, but then we didn't block off dates to actually input it into the system. And so we could then be from January till April sometimes actually getting it input before we could have the benefit of seeing the results of the survey that we did in November. And it seemed like it was double work, but it seemed like it would be too daunting to try and use the computer and input it directly into the database. We felt it would be slower, and it would be harder to get more people to be a part of it, because then that limits the number of people, getting people access to the database itself. So we hadn't done that. We looked at some other things. We thought that if we had more people, so especially in our tertiary care facilities, there's one AMS pharmacist, and then there's some, Paul would help, and I would come in and help, and some of the residents that are with the ID would sort of come in and help, but it still was a lot for that one site. So we had the idea that maybe the clinical pharmacists on the unit themselves could do the data collection, and then we would do the assessments and the data input into the NAP system. And that seemed like it might be a really good idea. The data collection end of it went really smooth. The problem is that when we got these sheets, even though we did do education with the staff of exactly what kind of data we were looking for and what we would need, we found that we were missing some of the key pieces of information that we would need to do an appropriate assessment, and had lots of other information that wasn't necessary. And then we still had that backlog of actually trying to get it into the system where it would be usable for us. So that really, as Paul had mentioned, we've gotten much better and quicker with the assessments because we're the same ones doing it every year, and we're getting a sense of where we put that. Trying to bring all kinds of people into the system that aren't using it on a day-to-day basis does not work. At least we didn't find that it worked well. So we have we abandoned that aspect and didn't do that. But what we did just this past year that I think did work so much better, we did find that it was a much smoother process, was we did enter into the database right as we did the assessment on the floor. So we went up with laptops and we entered the data as we took it from the chart, the paper chart, into the NAPS data system, thereby eliminating that duplication of work of putting it in after the fact. So we got rid of the paper and did it all electronically. We did bank on this taking more time, so we had allowed more days to actually do the assessment on the sites. Probably gave ourselves double the time of what we had done in the past. But in actuality, we found it didn't take double the time at all. Most of the sites we were able to do pretty much in the same amount of time, about 1.5 days for the sites that were around 120, 130 beds. And ones that were a little less, we could do in a day. And then the other thing we did for these larger tertiary care facilities is we did, rather than a full assessment, a full point prevalence survey, we did a random sample. So we would print off the list of the patients on each unit, and we would do every second patient. So not every second patient on an antimicrobial, but just every second patient would have a chart review, and then we would treat it exactly as a full review after that. And that made a huge difference in our very large facilities to be able to get really good data. It was still gave us good, accurate data. We didn't notice that the numbers seemed that different as the total percentage on antimicrobials. The indications and the choice of antimicrobials seemed very much in line with what we were seeing in previous surveys. So in these larger facilities where it's a lot to just do one, like the whole hospital, I would recommend trying the random sample, and that would certainly cut down on the work greatly. So we this year had everything done by Christmas, and then we could get the data out of the system, and it was so much easier. So our recommendation would be to anybody looking to start this is to forego the paper, do it directly into the computer, and also do the randomized sample. The other key that we talked about and Paul sort of mentioned was that when we did it right into because our pharmacists are now our AMS pharmacists who've been doing this year after year, we're getting much more comfortable with the assessments. And so a lot of them, we could just do the appropriateness assessment as we got the data from the chart. And so there was only a few that we had to come back and meet as a group or chat with other pharmacists or ID physicians to sort of come to an appropriateness assessment, which has really made things much smoother each year that we do it. So a little bit of practice. So we use students. We do bring in some extra help, not to the degree that we did that one year of everybody doing their own unit. That wasn't helpful. But a smaller group that can help, and then we're sort of right there side by side with them, helping them make assessments of what's needed, but it does help to decrease the workload. So those are our learnings and our suggestions on ways to sort of incorporate this into your workload to make it something that's doable, because I do see the value in putting a little bit of dedicated time into taking these surveys. So And with that, that's kind of the end of our presentation. So we'd be open to any questions.